Hi, everyone. I am Carolina, and today I'm not going to talk about a clinical case, but right now, the last week, I went to a congress in Bogota that was the Pan American Congress of Ophthalmology. And 1 month ago, I was in Ecuador in the Congress of Clínica Santa Lucía, that it was an international congress too. And then in the two congress, they talk about two topics that I really want to talk today, because I think that there they talk them about like two things that are important to know, that although we are all familiar here in the Hospital de la Familia, we are familiar with them, were heavily emphasized by several doctors during the Congress. So I'm bringing them up today for discussion. And I search for articles to back up the topics discussed. So I start. Um, okay, so the first topic is ally or enemy, the role of the crystalline lens in angle closure glaucoma. So I know that this is not the first time that we talk about this, because here Melanie always told us the importance of the cataract surgery in angle closure glaucoma, but I want to talk about this. So primary angle closure. So it's an anatomic abnormality that results from pupillary block due to contact between the crystalline lens and the posterior surface of the iris. The peripheral iris then bows anteriorly to occlude the angle and prevent aqueous outflow through the TM. The PAC is comprised of a spectrum of patients classified into three groups, that we have PAC suspects, that is when we have with it is occludable, it has narrow angles. The PAC, that is when it's occludable, narrow angles with high IOP, peripheral anterior or excessive trabecular meshwork pigmentation, and the PAC glaucoma, that is the PAC, but with optic disc changes. So in this article, role of cataract surgery in the management of a glaucoma, it talk about this. So PAC is commonly found in moderate to high hyperopes. These eyes typically have relative short axial length, and the anterior chamber angle appears narrow gonioscopically. Eyes on the PAC spectrum can often be identified and treated prophylactically before damage develop. If a cataract is present, removal of the crystalline lens and replacement with an implant intraocular lens has been demonstrated to widen the anterior chamber even better than the iridotomy. So this is something that we know here in La Familia, and this is the the examples that the doctors there show us. So they emphasize in the structural change in ocular architecture following the cataract surgery. So this was the picture that they show us of the clinical case, and we can see here at the left, we can see in the slit lamp examination that we don't have an anterior chamber. We can see the cataract, and we can see like in the narrow, like the light, that is really tiny, the anterior chamber. And here in the right, we can see the big difference of all the anterior chamber that is really big now, and we can see the angles. So this was a patient that they show us that he started in the left eye, he was with 45 of IOP, and then they only did the surgery, and it was now in the right in 12 mng of IOP. This is another example that they show us in the Congress. We can see the difference between the picture up that we can see the old cataract that is really big, and the difference in the other picture that we can see we can see here the angles. So this is talking about when we have a cataract. So it's easy to say, like, if we have a cataract, we have to operate. But the issue is what happens when we don't have a cataract. We have a clear lens, but we have narrow gonioscopy. So so what is recommended to do in presence of a clear non-cataract crystalline lens in eyes with PAC? So now I want to talk about this study. I don't know how to raise this. Oh, wait. Okay.
All right, leave it.
You can see like the circle in orange that I'm.
But that's fine. You can leave it.
Okay. Okay, I don't know how to raise it. Okay, so this is the Eagle study that is the effectiveness of early of primary angle closure glaucoma. So it was a participants, it was 150 with primary angle closure and 263 eyes with primary angle closure glaucoma. The inclusion criteria was the baseline. The IOP has to be more than 30 millimeters of mercury in the PAC arm, and the patients with primary angle closure glaucoma patients must have had IOP more than 21 documented at least once. Okay. Okay. So the methods were 280 eyes underwent clear lens extraction and 211 underwent standard of care treatment, laser peripheral iridotomy, and escalation of medical treatment. The results was that mean postoperative IOP 36 months after the treatment was lower after clear lens extraction compared with the standard of care treatment. The patients from the clear lenses structure group also had better visual acuity. That was very important. And the interpretation of this study is that clear lens extraction showed greater efficacy and was more cost-effective than laser peripheral iridotomy and should be considered as an option for first-line treatment. So this is talking about the clear lens. So the key findings with this is that the lens plays a fundamental role in the pathogenesis of angle closure glaucoma. The management of patients with cataract should be surgical and should not be delayed, and the clear lens extraction is indicated as initial treatment for angle closure glaucoma, prior iridotomy, and persistent elevated IOP. So they were talking about that sometimes it's not enough, the iridotomy, so we have to think in the surgery, even if the lens is clear. So this is the one topic, and the second one is about the SLT. So rethinking glaucoma treatment, the SLT laser as the primary approach.
Carolina, can I make a comment on that first part?
Yes, of course.
I think that we should do we should always think about the mechanism of the glaucoma. Always do a gonioscopy, look at the iris, look at the if it's an iris plateau, and if it's the lens, we could do a UBM and measure the vault and see if it's there's an anterior bowing of the lens. And I would think that if there is a positive anterior vault, then those cases might benefit from removing the crystalline lens. I just don't want to leave the idea that everybody who has a everybody needs a clear lens extraction. That's I just want to clear that. Just want to clear
Yes, of
that.
course.
Okay, we need to do a goniotomy. We have to have a gonioscopy, sorry, and we do have to have a UBM to see if there's a positive vault. And then you can, and then sometimes if you find synechia, you can do synechiolysis as well. And that can also free the TM and the pressure can come down certainly. So just a comment there, but we're not removing clear lenses to everybody. Just
Jorge, can I ask
Yes.
one follow-up question on that? When you
yeah,
say we're not doing clear lens extractions,
on everybody. I mean, as
right?
a glaucoma consensus,
Yeah,
I think that it should be. I mean, this study was made in Asia and patients over 50. So I mean, there's clear demographics there that we have to separate from our population. So
do you think it's appropriate to think that anyone over 60 coming in with
oh yeah.
that's not going to be a clear lens extraction, that like even if they look normal on gonioscopy, would
I
you
mean,
worry that the lens is going to change continually in that decade of life, and therefore if it looks narrow clinically, even though the angle's open, that you would go ahead and take that lens out?
all right, so
Or
we're talking about primary angle closure glaucoma. So this patient has had high pressures, has optic nerve damage. That's what we were talking about, right?
yeah,
All right. So you did an iridotomy and the angle's open. Now, that's where the case is where you're saying, and then she has some cataract and she's 60 now, and her pressures are fine, right?
yeah, yeah.
So, question is, what's wrong with that? I mean, she has some damage, but if she doesn't have high pressures now, she doesn't have cataract. So what are you treating? I'm just asking.
Yeah, so you're saying but if she didn't have the PI, um, well, I mean, what's the role where you would do this cataract surgery uh,
So,
after the PI? If the PI relieved the pressure and relieved the relieve the angle of the iris bowing, and you saw a good flow after the PI, when would you not do that cataract surgery?
oh, okay. So I would do a UBM. I would try to look at the angle, try to make sure there is no iris plateau, and try to make sure and if there is no anterior or positive vault, um, I would treat that angle just like that. I wouldn't remove the lens because it's not the lens that's causing the problem. I mean, it's something else. But if there is anterior vault, a positive vault, I mean, that's what we call it, then then um, then go ahead, remove the lens, because then that's when it's going to open the angle. Yeah. What do you think, Melanie? Do you think what do you think?
So, hi everyone.
Hi.
Um, this is a topic that I really enjoy. So, as Dr. Hernandez said, I would always consider the mechanism that's causing the angle closure, right? So, a lot of the percentage of patients with primary angle closure have pupillary block as a principal mechanism of angle closure, right? And that's what you relieve with the PI, just the pupillary block. But you can also have, for example, a bulky lens that is causing a positive bolt, and that's what is causing the angle closure despite relieving the pupillary block. I think that's what Dr. Hernandez is referring to. If that was the case, if I notice that the angle is not open, or at least there's still some irritated trabecular contact, then I would remove the lens, even though it is clear. But I would always confirm with a UVM. That's something that we usually do, because there are other mechanisms that can cause angle closure. For example, iris plateau and pseudo-iris plateau. So for me, as you were asking, Dr. Sorensen, I would say you have a patient who's a primary angle closure suspect, then you discuss the options with the patient. You consider the age of the patient, visual acuity, how the lens looks, if it looks like it has some cataract in it or it doesn't. If it's a clear lens, then I would probably go with a PI, or maybe just observation, even depending on the degree of angle closure, the IOP and stuff. But if the patient has, you already did the PI, the patient has good visual acuity, the patient is 60 years old, some mild cataract, I would discuss it with the patient. I would let them know that it's not a problem now, but it could be a problem in the future. So maybe, I mean, I always advocate for cataract surgery as early as we can, especially in patients who have angle closure, because those cataracts are going to be hard cataracts to get out of small eyes eventually, right? So it's better to get them out before they turn into rocks, right? So I wouldn't take out, as Dr. Hernandez said, I wouldn't take out all of the clear lenses, but I would consider each case individually. And if the patient already has a degree of nuclear sclerosis, like maybe they have good visual acuity with the right correction, but maybe you could discuss the options with the patients. I wouldn't like ask them to wait until their cataract is like super hard to get out, because I know those patients are probably gonna have like a lower density of endothelial cells on the long run because of the angle closure, the high IOPs, if they had IOPs previously, especially in those cases. And also I know that those are usually small eyes, so it's not going to be like a straightforward gaze. It's probably going to take some maneuvering and stuff, so I would rather to take out that cataract before it gets denser. I don't know, does that make sense to you?
Yeah, so I guess the advice is that kind of, it sounds like as the patient's aging, you're more likely, even if you don't think the lens is playing a role, you're more likely to encourage its removal because it might pose a problem. And
Sure.
Jorge, you're saying if on the other end, people who have no lens involvement, the narrow angle can just be narrow all by itself without any role of the lens or that whole lens apparatus.
Yeah, well, there's a few causes. I mean, that's as we mentioned. I mean, there's just, it could be thick iris, it could be a plateau iris. You can have the lens pushing forward, and Melanie mentioned this, and it's about 30 to 40% of the patients have just pupillary blockage, but about 40% of the patients have a mixed mechanism. So you do a PI, and they're still shallow, or the angle is still closed, and that's the role. That's another discussion we have to have, like how many times do we do gonioscopy after a PI? I mean, that's really important. So we go and look at the angle, and hey, it's still closed. Maybe I should do an argan trabeculoplasty because it's a plateau iris, or take the lens out. I mean, but you have to look at the angle after the PI. That's the best answer.
I just want to chime in real quick on this. The imaging was mentioned a couple times about the UVM, and in my experience, also OCT can be helpful, even though you don't see the shadow behind the iris. But what you can see from OCT, which more people have than UVM, you can really see the relationship between the pupil margin and the anterior chamber and the thickness of the lens. And the patients that really do need a clear lens extraction is pretty obvious. I mean, even on the picture that was shown is pretty obvious, because and also when the Eagle study came out, I was excited, like, hey, yay, I get to do more lens surgery, yay. But it turned out to not be such a free lunch, because these are also the patients that are the worst possible patients to do surgery on, because you think your phaco tip is 1 millimeter wide, you look at the anterior chamber depth is 1.8 millimeters, and the anterior capsule is extremely domed. So a combination of a shallow AC, a domed anterior capsule, and what you frequently get also is a lot of zonulopathy with these patients. These are tough cases. These are not free lunch. And I'm sure anybody who's done these will know what I'm talking about.
That's right. That's why you have to, I'm not pushing for all patients, but I would say, a bit picky. All right, Carolina, go ahead.
Okay. So the second topic that I'm going to talk about is rethinking glaucoma treatment, SLT as the primary approach. So I found this article that is selective laser trabeculoplasty as first-line therapy. So again, I know that we all know these things, but maybe we don't have, like, we don't put in practice every time, like for one reason or for another. And it was like, I decided to talk about this because in the two congress that I was, they really emphasizing this. So I decided to talk about this. So the efficacy of the SLT, the light trials show that 74% of patients treated with SLT remained medication and surgery free at 3 years and 70% at 6 years. So SLT significantly reduces glaucoma progression and the need for surgeries like trabeculectomy and cataract surgery. It is equally or more effective than eye drops in controlling intraocular pressure. The safety is that no vision-threatening complication were reported, fewer adverse effects compared to eye drops, which often cause ocular surface disease, and the adherence up to 60% of patients do not adhere properly to topical therapies. That 60%, I think that is a lot. SLT eliminates adherence issues by shifting control from the patient to the physician. So the cost effectiveness, SLT is more cost effective in the long term than eye drops, reducing healthcare system and patient expenses. The multi-drop therapies offer diminishing the return and increase the clinical and economic burden and barrier and solutions, common obstacles, perceived procedural complexity, and patient fear of gonioscopy. The solution is proper patient education, verbal anesthesia, and direct SLT with no contact as a faster, more comfortable option. So in this article, the author says that she have found that the biggest barrier to first-line SLT is that the patient's fear of intervention. And the SLT takes an average about 5 to 7 minutes to complete. So in this article, the author talks about one SLT, that is the Voyager of Alcon, that it is an option and it's with no contact and it's faster. And Mariana is going to talk about the Voyager Alcon next week, so I'm not going to talk about it right now, but this is also an option of SLT. And this article also, that is first-line treatment, SLT, or only medication. So which to choose, how to choose? SLT as a first-line treatment in untreated patients with IOP in the mid-20s. Start with medication if IOP is very high, like for example, 45 or 50. Take into account the target intraocular pressure when recommending treatment. An option is to start with prostaglandin analogs, and if the target IOP isn't achieved, add SLT as a second-line therapy. So it's also another kind of treatment. And in this one, that it was a talk about the first-line advantages of SLT. SLT can lower IOP, reduce medication use, and provide key diagnostic information. Toxicity is a risk for virtually all topical glaucoma medications, including newer prostaglandins. And SLT versus prostaglandins that it's talked in this article is that the studies comparing SLT to prostaglandin found it to be a safe alternative for primary glaucoma therapy with similar outcomes and far less need for additional therapies in the first year. It is lower IOP at 6.6 millimeters and studied side by side with latanoprost. SLT reduced IOP at least 20% in 75% of eyes compared to 73% of eyes for latanoprost. So we can see here the Congress picture that they show us. It was here we can see like the orden del tratamiento of glaucoma, that it's the first SLT. Then the second, they propose the deposit medicament, that is, they talk about the Durista, that is intracameral bimatoprost implant, and the iDose, that is the travoprost intracameral implant. Then in third place is the cirugía, the mix that we all know. Then the MIPS, and then in five, like a five option, they talk about the trabeculectomy or the Ahmed valves. And this was in one, and then they also talk about this, and they talk about the SLT as the first treatment. Another thing that I want to know what you think is that some doctors says that they prefer to make the SLT only like 180 degrees, and then 1 month later they complete with another 180. Another people said that they prefer to do all the 30-60 degrees. So it was also a discussion. And okay, that's all. Thank you for listening to me.
Melanie, I have a question for you and Jorge. We've had this discussion about drops versus SLT at the hospital many times. And Melanie and Jorge shared that they thought that the reason people didn't pick SLT was the word laser. People didn't want that. And so Melanie, you and I in a group talked maybe a couple of months ago, you were going to try to present to patients SLT, but you were going to call it something else. You were going to call it like light assisted therapy or something like that, to see if the acceptance rate was higher. Have you tried that new way to present it without the word laser, and has that been successful?
So not recently, but I'm gonna start doing it more often from now on, because we didn't have the SLT lens, or I mean, we had one, but it was all scratched. So we were waiting to offer more SLT until we had the new one, the new lens. Now we do have the new lens. So I guess we can all start calling it like light assisted therapy or something else, like no pain, super fast, no drops and stuff. But yeah, that is something that we discussed previously. And I think it's something that we can maybe push forward and improve now. So yeah, thank you.
Keep me posted. I'm very curious how that works. Keep me posted.
Yeah, sure. Absolutely.
I noticed Carolina had put on her presentation, one of the obstacles for SLT was patient fear of gonioscopy. And I think that might be slightly misstated. I think it should be doctor fear of gonioscopy. But setting that aside, I think Mariana is going to talk about the DSLT. We purchased a DSLT 3 months ago, and our practice's SLT rate has gone from 5 patients per month to 60 patients per month.
Wow.
So we'll show you some videos and whatnot next week.
Wow, that's impressive.
We talked about petitioning Alcon to get us one of those, and I think we decided to wait a year, right? That was the vote before we threw our efforts towards that. But yeah, that'd be interesting, Eric, to see how you. I think Jorge, also, I've been doing gonioscopy more since you said that. I just wanted to tell you that.
Eric, are you? There was some discussion about this new machine that "quote unquote" a technician could do it. Who is actually doing that in your office?
I am. I mean, me or the other ophthalmologists. Only the ophthalmologists are doing it. The technicians are definitely not doing it. I definitely don't recommend a technician doing it. In fact, when I got my machine, I called Paul Singh, who was referenced in the talk. I asked Paul, because Paul's been doing it for about a year, and he was part of the trial, and I kind of chatted with him, and he gave me some very, very helpful tips. Even though it's quick, there's some important technique things that make a difference. I wouldn't recommend it for technicians.
Okay. I think that was one of the selling points, quote unquote, in that it was less physician involvement, but may or may not.
I would strongly advise that a doctor who does surgery do it.
Okay.
Eric, can I press you on that, Eric, and ask you why that is?
Because you're delivering a powerful light source that will damage other structures. I haven't had this problem, but I've seen it hit the cornea and cause a bunch of corneal inflammation. I've seen it hit the iris and cause transillumination defects, and irritate the sclera. The eyes can, if patients don't take NSAIDs, the eyes are much more inflamed than after a standard SLT, because the delivery externally, it's a more pro-inflammatory treatment than the standard SLT, to be sure. Just because it's quicker, and it to be sure, it is easier for the doctor and patient. There's definitely a technique to it. I mean, that's been my experience.
Okay, thanks.
And have you noticed the IOP drop that they offer?
I found it to be very similar. In fact, I think I'm getting a good response in about 75% of patients so far. I'm just now seeing that first wave of patients come in that's 6 to 8 weeks later. Okay. So, I saw a patient today, his pressure was 25, and today it was 17. So that's a pretty darn good response.
Yeah.
So.
Great. All right. Thank you, Carolina.
Thanks, Caro.
Eric, do you do SLT?
Yes.
Yeah, I've always done.
What's that?
You do 360?
Yes. Yeah, I do 360. But the reason is, and this is why, why don't we do more SLT? If I'm doing this many, DSLT, why wasn't I doing more? Because it's a pain in the neck. Getting the patient there, sitting there, it's fiddly. I mean, I had a patient, vasovagal and pass out once. I mean, it's a pain in the neck to do. So I want to get the maximum response right off the bat. Heaven forbid I got to come back in a month and do it again. So I'm just going to do 360 right off the bat.
I agree.
For the best. So I never do 180. I mean, maybe 20 years ago I'd do 180. Always 360.
I do 180 in the pigmented patients. Very pigmented. We have, but that's
sure.
Yeah.
Super. Those 4+ TM pigmentation, sure. But otherwise, I just want to get it over with.
I'll bet Bob, myself, and Becca, I'll bet we do 5 to 8 a day SLT. So I wonder why that is. I wonder if it's more. I don't think we have more glaucoma patients. At some point, we pivoted to doing more of those early on. Interestingly, I think where laser is not a popular Guatemalan word, it's really popular in the Bay Area of California. People really like the idea of using a laser since they were invented at Berkeley, or a lot of them are. So that's interesting.
You're doing your little. Other thing we talked about was to tell the patient that if it was your eye, you'd prefer to have SLT versus drops. We thought we might try that as well.
All right, guys. Thank you.
Thanks,
you,
everybody.
Thank you very much. Okay.
Yeah.
Thank you,
Bye.
everyone. Thank you
Thanks,
for the
Caro.
discussion.